So Neil's case is just really perfectly indicative of what we wanted to do when we set up this process. So our process for one of our patients that are experiencing an inpatient stroke, we really wanted to make sure that they're getting the same standard of care that our patients are coming through to the emergency department are.
I was having chest pain, so I come in and figured I needed a stent. So I came in and they put me in a room and checked me out and decided to keep me 2 or 3 days, just check me. And that's when the stroke hit me.
It's probably 2 o'clock, around 2 o'clock in the afternoon. I was doing my rounding and I walked in and noticed some signs that definitely had signified that Neil had had a stroke.
He was having slurred speech, difficulty speaking, was just confused. And so immediately called a rapid response. The team came with a rapid response and we immediately did interventions to help save his life.
I was in my office when I heard the rapid response called and left my office to go see the events that transpired. The teamwork and communication was just flawless between the CNA, the nurse, and the ICU team, and everybody else downstream. Just happened flawlessly.
Yeah, so process, we get a pager, a code. We run as soon as we can down to the ER. We come in and sort of assess the patient rapidly. We do a code stroke assessment called the NIH scale. It tells us what we're dealing with. Is this a severe stroke, a mild stroke? So we run through that assessment, communicate with the ER physician, and then we get to imaging as quick as possible. CT scan, almost always, sometimes MRI. And once we're there, we rapidly evaluate for bleeding. If we don't have bleeding in the brain and they're a candidate for something like TPA, a clot-busting medicine, then we give it.
So the whole continuum of care for our stroke patients is imperative. It's very vital. So going as quickly and as efficiently as we can through the process of identifying the patients, getting the studies done, and then getting them to their definitive treatment, it means everything. And that's why Brent's father, Neil, did so well, is because we were able to find it quickly. Well, the team was able to find it quickly. The team was able to treat it quickly and get him to the cath lab, and all the cath lab individuals, which are many more people than just me, were able to get in, and we were all able to do our job as a team and then get him to the ICU for recovery and treatment after. So there's a long continuum of care, a lot of people involved, and each person had to be doing their job to the best they could to get this done.
And what was significant about the evaluation was really the lack of deficits that we normally see. Typically with a stroke in this area, when patients come in, they'll have significant loss of movement on that one side, possibly difficulty swallowing, possibly difficulty communicating and thinking. And when I evaluated Neil, most of the deficits were pretty minor.
Probably if I hadn't been here and they hadn't treated me like they did, I would have not made it. I'm sure I would not have made it. And I wouldn't have had all my faculties with me now.